Hey guys, just waiting for welcome. It's World Kidney Day. I'm just gonna wait around for a few more people, and then we're gonna start. Okay, let's just see if anyone shows up. And if you're here, if you get here, just do me a favor, put a like button, or tell me where you're from. All right, guys, I'm gonna go ahead and get started. All right. What's up, San Antonio and world? I'm Dr. Qasim Butt, and I'm a kidney doctor. I'm here to break down health in a simple way. Now, do me a favor, hit that like, share, and subscribe button. It'll really help me out. Guess what? It is World Kidney Day, and I'm here to talk to you about kidney disease, one of the biggest problems we have in this country, but some reason goes ignored. Okay, I've been involved in this field for quite some time. Really passionate about raising awareness and all that kind of stuff. And today I wanted to bring some light to the actual disease process and what's going on with it. Okay. So let's go ahead and get started. All right. So what's the problem here, guys? What's the problem? Why do we have? What is the problem? How do we identify it, and what is it? Well, the problem is it's the most expensive disease y'all ain't heard about. Okay. In 2016, Medicare spent over $114 billion to cover people with kidney disease. That represents about $1 in every $5 that they spend. Yes, $1 in every $5 Medicare spends goes towards kidney disease. And the average lifespan of someone on dialysis, I want y'all to guess. Just take an idea. Give me an idea what you think it is. It is 5 to 10 years. 5 to 10 years, guys. So if you think about it, if you were diagnosed with cancer and you were told you had 5 years to live, that would scare the crap out of you. But 60% of people that go on dialysis don't make it to 5 years. Okay. So this is something you guys, our patients don't get that level of urgency or attention that other disease processes do. A little about me. I have 11 years of clinical experience. I'm both a clinical and interventional nephrologist. I'm able to handle issues with dialysis access. Like fistulas, grafts, catheters, all that kind of stuff. Over the years, I've had various leadership roles in hospitals and in kidney foundations as well. Last few years, I gotten involved with social media. Please follow me on those platforms if you can: Twitter, Facebook, LinkedIn, YouTube, of course. I've done public speaking and education about kidney disease. And in the last few years, I've gotten involved with value-based medicine. I've actually been asked to present about Medicare's new kidney care models to UT Health San Antonio. So I've gotten to be very knowledgeable about those. But the biggest change in the last few months for me is I got involved in innovation in healthcare, particularly kidney care. I've gotten advisory roles in certain startups as far as Aleo, Icona, and Dr. Pedia. Really proud to be a part of those. Aleo and Icona are specifically about innovation in kidney care. Let's just go over what it is. Let's just go over what the kidneys are, guys. Let's just see what are the kidneys? What do they actually do? Well, the kidneys, they're a pair of vital organs. They're bean-shaped. They're about the size of your fist, about 5 inches or so. They sit in the middle of your back area, back over here. Okay. Now, what do they actually do, though? They go through about 200 quarts of blood in a day and sift out about 2 quarts of waste products and extra fluid. All right. So essentially, you got to look at the kidneys. The kidneys are sitting there. They're always making urine. They're making urine. That urine is actually going through ureters down into the bladder. And when they go down into the bladder, the urine is actually stored in the bladder. When the bladder is full, that's when you have the sensation to pee. So you only pee occasionally, but you're always making urine. Okay. What do the kidneys do? Well, more than you think. Okay. They remove waste products from the body. All right. They remove waste products from the body. They balance all the body's electrolytes, sodium, potassium, phosphorus, all the things you find in Gatorade, guys, all that stuff you find in Gatorade. Well, that balance is played by the kidneys. Okay. They remove drugs from the body. Okay. Whether those drugs be over the counter, prescription, or extracurricular, the kidneys play a role in removing them. Okay. They balance the body's fluids. And so what that means is if your kidneys aren't working right, you could develop swelling in the feet or get fluid in the lungs. And oftentimes swelling in the feet may be a sign of kidney disease. They release hormones that regulate blood pressure up and down. They produce active forms of vitamin D that help promote good bone health as well. And they control the production of blood. Yes, they're involved with production of blood, secreting a hormone. And that's why people with kidney disease oftentimes get anemia. All right. With all that being said, I want you to take away the kidneys are a filter, a very sophisticated filter. Okay. Now, there's two types of kidney doctors out there, a nephrologist and a urologist, and many people don't know where the lines are between us, including some doctors. I'm just going to put it out there, okay? I'm a nephrologist. I'm in charge of the kidney function. I use medications and can do dialysis. A urologist is a surgeon. They use a scalpel, okay? They're in charge of things like cancers, stones, prostate issues, urination issues. The way I like to look at it, just to simplify it, I'm a kidney doctor. I'm a type of kidney doctor that handles the kidney function. The urologist handles the plumbing. Okay, they're the plumbers. Okay, so they're involved with all the urine flow and all that kind of stuff. Okay. Now, what is kidney disease? You've heard this term. What does kidney disease actually mean? Well, let's just break it down into two types of kidney failure. There are actually two types of kidney failure. One is acute, which means it's sudden. Okay, so what that means is your kidneys are suddenly injured, and the kidney function drops, and it lasts for maybe hours to days, and then comes right back up. The most common cause of this is dehydration. You get dehydrated, the kidney function drops. You rehydrate, the kidney function comes back up. The other form is chronic, and chronic means the kidney function comes down, but then, dude, it stays down. It stays down, okay? It stays there long, and that lasts months to years. And that goes to a term called chronic kidney disease, okay? And that's defined as having a decrease of kidney function for 3 months or longer. So your kidney function comes down, stays there for 3 months or longer. And or if there's a marker in the urine, meaning if there's any blood or protein in the urine. So your urine is supposed to be clear, no evidence of anything in it. If there's blood or protein in it, that's a sign of kidney damage, okay? And most kidney disease, the kidney disease attacks the nephrons, okay? So the kidneys are a giant filter, but they're actually made up of microscopic filters called nephrons. I think there's about 1 billion of them in each one of your kidneys. And so the kidney disease slowly destroys those nephrons over time. And that's why kidney disease is slow and silent, taking many years and with very little symptoms, okay? Now, kidney disease itself is a serious problem, y'all. 37 million Americans are affected by it, 14% of the U.S. population as a whole. 9 out of 10 of people that have kidney disease don't even know they have it, okay? And the prevalence, there's more prevalent in older populations and certain minority populations as well. If you're 60 and older, you have about a 25% chance of having kidney disease. And certain populations, particularly Blacks and Hispanics, are predisposed to having kidney disease. I trained at LSU in Shreveport, Louisiana, with a large Black population. I'm here in San Antonio with a large Hispanic population. And the kidney disease prevalence is quite astonishing. As far as the cost of kidney disease, as far as the cost of kidney disease, there's about 500,000 Americans on dialysis, guys. 500,000, 500,000 Americans are on dialysis. Dialysis costs the U.S. over $30 billion a year, $30 billion, right? And the primary payer of dialysis is Medicare. I bet you didn't know that, okay? Now, Medicare itself, as most people understand, is an age qualifying insurance, right? You turn 65, you qualify for Medicare. Well, there is an exception to that, and that is the diagnosis of end-stage kidney disease, okay? In 1972, Richard Nixon actually signed that into law that Medicare would actually cover people with people that require dialysis, okay? Now, back then, I think there's only 10,000 Americans on dialysis. Now there's over 500,000. And in 2016, I want you guys to give me an idea. What do you think it costs to maintain a human being on dialysis for a year in the United States? 1 year. In a year, how much does a dialysis patient cost the U.S.? Put your numbers in your head, throw them out there, maybe put them up on in the comment section. Well, it's actually $90,000. $90,000 a year to maintain a human being on dialysis, which is ridiculous if you really think about it. That's how expensive dialysis is, and kidney disease costs this country. Now, as far as detection of kidney disease, how do you detect it? Well, you can do a blood pressure check because kidney disease are directly related to blood pressure control. You can check a urine looking for blood or protein, like I mentioned. Okay, and you can do a blood test called a creatinine. Okay, that's a kind of common marker for kidney disease. Now, how well the kidneys are doing? How do you say how well the kidneys are doing? What number tells you that? Well, it's a number called eGFR, which is the estimated glomerular filtration rate, and that's actually based off the blood test of serum creatinine that we just talked about. So they get the blood test of the creatinine, do a little calculation, throwing in your age, your race, your gender, and other factors, and come up with this calculation of eGFR. Okay, the normal eGFR is like 100 to 140, something like that. But to simplify it, I always just tell people It's in a percentage term. So if your GFR is 35, I'm going to tell you have 35% kidney function, just to simplify for you. Now, there is a gold standard of detecting how well your kidneys are working. That's called a creatinine clearance. But that is based off a 24-hour urine. Okay, yes, you have to collect your urine for 24 hours. Got to keep it cold, either on ice or in your refrigerator by your Kool-Aid. Okay, so it's kind of gross and cumbersome. Okay, that's the main problem. This is really cumbersome. It is more accurate, but because of how cumbersome it is, we don't really do it that often. Okay. All that being said, when you hear the term eGFR, think percentage of kidney function, guys. Percentage of kidney function. As far as stages of kidney disease, you have to know there's different stages, 1 through 5. 1 being the least, 5 being the worst. Okay, 1 is when the kidney function is above 90%. Above 90%. Stage 2 is when kidney function is between 60 and 90%. Stage 3 is large, between 30 and 60%. That's actually broken up now into 3A and 3B. Stage 4 is more severe when your kidney function is less than 30%. And stage 5 is when your kidney function gets to 15% or less. And that's when you really, kidney function is gone and you probably need dialysis. And this is kind of the disease progress. You kind of start from 1, 2, 3, 4, kind of going worse. By the time you make it to 5, you probably need dialysis. Okay. Now, people at increased risk for kidney disease, they're typically older population, diabetics, people with high blood pressure, family history of kidney disease, and as I said, mentioned certain ethnic groups as well. You can see on this chart here, Hispanics and Blacks are more predisposed to it. As far as symptoms, guess what? Early stage, none at all, guys. And that's what's weird. It's like I get patients in my office and all of a sudden they have 30% kidney function and they're like, I never knew. And you wouldn't have any symptoms. So the early stages is no symptoms. So this is why it's kind of crucial to see your PCP regularly and get checked. Now, late stage, when you're coming closer to dialysis, you can have urination issues, feeling tired, weak, appetite issues with nausea, vomiting, things like that, sweating of the feet, shortness of breath, all that kind of stuff as well. So this is where it's crucial to get detected early. What causes kidney disease? What actually causes kidney disease? That's the big question. Well, how do I avoid it, right? Well, there's a concept out there called the Pareto principle, which is the 80-20 rule. Many of you may have heard of it, but it essentially says 20% of your inputs lead to 80% of your outputs. 20% of your customer base leads to 80% of your revenue. 20% of your efforts leads to 80% of your output, right? And that's kind of a principle out there. It's in the business community, but just a general economic principle. But I want you to take a look at this list if you can see it. There's tons of lists of diseases here. There's autoimmune diseases. There's genetic diseases like polycystic kidney disease, IgA nephropathy, other diseases as well, injury from medications. And guess what? This list even goes far further than this, probably dozens more. Okay, but of all that list, these two are the biggest problem: diabetes and high blood pressure. That's right, just those two diseases. If you see here, this is US RDS data. You can see here, diabetes and high blood pressure make up 65% of the problem. Okay, so the way I look at it in healthcare and in kidney care, you put 65% of the problem is diabetes and high blood pressure. The other 35% is rare disease. Okay, that's how I like to address it, because I think you have rare disease and then you have diabetes, high blood pressure, and all the socioeconomic issues and behavioral issues that go along with those two diseases. Okay. Blood pressure. I'm just going to go on a little bit about blood pressure just because I am a kidney specialist. So that just makes you a hypertension expert as well too. What is blood pressure? Well, blood pressure is like, if you look at the body as a plumbing system, like in your house, blood pressure is the pressure within those pipes, right? It's the pressure within those pipes. If the pressure in the pipes in your house got too high, it would actually mess up those pipes, right? It may actually mess up anything connected to them, like the faucets and things like that, right? So that's what a blood pressure is, the blood pressure in there. And then you guys probably have had your blood pressure taken. There's two numbers involved. There's a top number and a bottom number. The top number is the systolic. The bottom number is the diastolic. The top number, the systolic, represents when the heart beats. The bottom number, when the heart, with the diastolic, is when the heart relaxes. Again, the top number is when the heart beats. The bottom number is when the heart relaxes. Normal blood pressure normally is around 120/70. That's where you kind of ideally want it, or less. Okay. Now, what is high blood pressure though? Well, high blood pressure is defined as having a blood pressure of 130/80 or higher. Okay. Now, in the past, it used to be 140/90, and that's how I trained for the longest time. But about 3 years ago, I think the American Heart Association came out with new guidelines saying 130/80 is actually high blood pressure. But blood pressure cannot be just taken one time to diagnose you with high blood pressure. You got to take it at least 2 or 3 occasions to make sure that your blood pressure is consistently running high. Okay, to define that, because your blood pressure can vary throughout the day. Now, if your blood pressure does remain high, the doctor will likely begin treatment. All right. As far as this is the vicious conundrum of high blood pressure, by the way. This is the vicious conundrum. Kidney disease itself can lead to high blood pressure, but high blood pressure in itself can lead to kidney disease, and worsening kidney disease can lead to worsening high blood pressure. So this is a vicious cycle that you can go into with kidney disease. As far as treatment of kidney disease, what do you do for it, right? What do you do? Well, what should you do as a patient? Well, you can attempt to control diabetes and high blood pressure. Those are the two biggest causes, right? So controlling your diabetes and high blood pressure is the key to controlling your kidney function, all right? You can stop smoking, lose excessive weight. The weight loss thing is a big deal, guys, okay? And what I mean by that, I'm big on lifestyle. People with, if you lose weight, you control your diabetes and high blood pressure better. Okay. In actuality, in many respects, the United States, we have all these diseases: diabetes, high blood pressure, coronary disease, diabetes. But in actuality, we have a big problem is obesity and being overweight, which is leading to these other diseases. The other thing you can do is limit your salt intake to about 4 to 6 grams a day, probably even 2, depending on what 2 grams a day, depending on your level of tolerance for sodium. The other thing you can do is also avoid certain over-the-counter medications like NSAIDs, non-steroid anti-inflammatory drugs. These are ibuprofen, Aleve, Advil, Motrin. Okay, these are those pain relievers. Do not get me wrong. I take them myself. I got a headache, I got a back pain, I'm going to take a dose or 2. The problem is when you take them consistently for long periods of time, you probably know people that have chronic back pain, and they're taking ibuprofen 3 times a day for months on end, right? That in itself can hurt the kidneys. Okay, just want you to know that. Now, what else can you do? Now, if you're late stage, probably stage 4 or less, or on dialysis, you're going to have to watch your potassium intake and your phosphorus intake. But I want you to understand that potassium and phosphorus do not in themselves hurt your kidneys. It's just when your kidney function gets so low, below say 30% or so, your kidneys can no longer filter and clean your blood, and they can no longer play the balance of electrolytes in your body like they used to. So you have to avoid certain foods that are high in that, particularly potassium. As far as medical therapy, there's no known cure for kidney disease. I want you to know that there's no cure. So what's the point in seeing me then? Well, if there's no cure, what's the point? Well, the point of seeing me is 4 goals. Slow the progression of the disease. So instead of your kidney function going down like this, like really sharply, if you come see me, we can kind of help level it out a little bit and prolong your kidney function over time. Now, we do that with certain medications, particularly blood pressure medications called ACEs and ARBs, and diabetic medications called SGLT2 inhibitors. All right, I'm not going to go into too much detail about that, but those are 2 medications, two types of medications you probably should be on if you have kidney disease. You can also treat the underlying causes like we talked about, diabetes and high blood pressure, big deal, treat those. We treat the complications of the disease. Remember, the kidneys do a whole lot more than you think. So we help manage anemia and bone disease that go along with kidney disease. And guess what? We replace the lost function of the kidneys. So meaning when your kidney function gets too low and you can no longer sustain life, we have to start dialysis. Okay. So what happens when the kidneys fails, guys? So your kidney is about to fail. The kidney function is less than 15% or so. And the doctor's like, hey, your kidneys are failing. What are your options? You got 3. All right. You got death, you got dialysis, and you got kidney transplant. Let's talk about that. Okay. This is a kind of a taboo subject, but I think we need to talk about it. Not everybody should be on dialysis. And I'm seeing a lot of people on dialysis. I'm like, you shouldn't be on dialysis. And the reason why is there's a lot of people, say 75, 80 years old, that have multiple comorbidities, multiple problems. And dialysis is not really helping the situation. Do you see what I'm saying? It's just prolonging misery. And some people at a certain age, what I've realized is like they become comfortable with their mortality, right? They say, hey, I've lived long enough. Don't want to suffer anymore. And this is where it's kind of crucial to have that talk with the family, talk with the patient, to get everything in writing, to make sure that maybe dialysis is not the best option for them. Okay. The next option is dialysis. I'm going to go into that in more detail, but there are different types of dialysis, which I'm going to go into. And of course, you have kidney transplant. Now, kidney transplant is another option where you can either get a living donor, which is get your mother, father, brother, cousin, homeboy from college, whatever it is, and ask them for a kidney. Okay. That's a possibility. Now, if you don't have a living person that can donate to you, you can also do what we call a cadaver kidney. Cadaver kidney means you get on a waiting list, wait for someone to die, say in a car accident or some other way, and that matches you blood type and everything, and they do a cadaver kidney for you. Okay. They when they die, they harvest the kidney and get it to you. All right. And the waiting list can be 3, 5 years or longer. As far as dialysis itself, I'm going to go over something important that what I call what I think is important is the patient experience and what the patients go through when they're on dialysis. Well, let's just talk about in-center dialysis. This is the most common form. 85-90% of people on dialysis do this in-center. In-center means they leave their house, they go to a facility to do dialysis, and they do that 3 times a week, either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Each session is 4 hours. Okay, 4 hours. So 3 times a week, 4 hours each session. And what they do on dialysis is they take the blood out of you, put it in a machine, clean it for you, then return it back to you. Okay. And that's done. They have to get access to a large amount of blood, so they have to actually get access in your arm, which is a fistula graft, or a catheter in your neck. I'll go over that with you too. So this is the inpatient dialysis center. You can see here that it can be a freestanding one, or it can be connected to a shopping center or things like that as well. The inside of that, you can see that some of these places have 10 chairs, 20 chairs, 30 chairs, depends. Now, these are the 2 biggest players in the market, Fresenius and DaVita. I think together they control about 70% of the market in kidney care. This is the in-center experience again. That's the chairs you'll see, and that's someone sitting there. And that you can see if their arms, you see the lumps there, that's the fistula. And I'm going to show you that a little closer. You can see here, this is a fistula. So you can see that lump going through there. That's actually the patient's own vein. All right. It's been artificially made to be bigger. And what they do is they stick the 2 needles directly in there, one to take the blood out of you, one to put the blood back in. All right. So they create that. Now, if you don't have healthy enough veins, they can create something called a graft, which is a synthetic tube. You can see it there like a loop configuration, but it can be used as well if your veins aren't big enough. Now, lastly, they can use is something in the chest. You can see right there. It's called a catheter. That's something we're actually trying to avoid. Okay. We actually want these access in your arm to start. It's called an optimal start on dialysis. The catheters are not a long-term solution. Yeah, they can be left for a few weeks or a few months, but ideally you want to get access in the arm because they can predispose you to infections and have all sorts of issues. As far as the patient experience on the in-center, so in the center, you'll have a dialysis tech that's sitting there that actually sticks the fistula. Occasionally the nurses will do it too, but usually the techs will stick the fistula. The nurse there is to be in charge of the patients themselves. There's a dietitian that discusses diet. You have a social worker as well too that handles all insurance issues, transportation issues, and a doctor. Doctor can visit you anywhere from 1 to 4 times a month while you're on dialysis. So what's cool about this is no other patient in America or in the system at all, like be it Medicare or commercial insurance, gets this level of attention, a full clinical care team that handles all your issues. So when you go to dialysis, you have a whole team there. And the problem I have is a lot of times, some patients don't utilize that team as much as they should. Meaning if you're a patient on dialysis, you should be asking a lot of questions, utilizing your social worker, your dietitian as much as you can to optimize your health. Okay. Now, the other type of dialysis, so we talked about hemodialysis. That was a home in-center hemodialysis. Let's talk about doing the hemodialysis, the blood dialysis at home. Yes, you can do it at home. And the frequency is different though. It's about 4 to 5 times a week. And each session is about 2.5 hours each session. Now, the prescriptions can vary. Don't quote me on that one, but everyone can be a little different. But generally, that's what we're looking at, about 4 to 5 times a week, 2.5 hour sessions. Okay. Same thing. That blood is taken out of you, put in a machine, clean for you. You have a fistula in your arm to stick the needles in there. It's more flexible, gives you more autonomy, which is super cool because you can do your dialysis, your 2 hours of dialysis before work, after work, midday, whenever you want, right? But you do need it. Oftentimes, depending on where you are, you may need a caregiver at home to make sure you're doing okay while the blood is being cleaned. As far as the home hemodialysis, there's 2 machines out in the market right now that I know of. Next Stage machine is the one that's been around for quite some time. Outset Medical's got a new machine out as well too. That's really user-friendly as well. The other last type of dialysis is called peritoneal dialysis. So if you don't like blood and you don't like needles, this is the dialysis for you. Okay. So this one is different in the sense you put a tube in your abdomen. There's a tube that goes directly into your abdominal area. Okay. You take a big bag of fluid and you put the fluid into your abdomen. It goes in your abdomen, sits there for a little while and absorbs all the toxins in your blood and through the lining of your abdomen, literally just through the lining, absorbs all the toxins, absorbs the extra fluid, and then you just drain it out. Put a big bag of fluid in, about 2 to 3 liters, drain it out. And you do that about 4 to 5 times a day. No need for a caregiver. Pretty cool, right? Now, there's 2 ways to do this type of peritoneal dialysis. There's the manual way, which I just described, big bag of fluid, drop it in, pull it out 4 to 5 times a day. But you also can do it by a machine called a cycler. You have that by your bedside. Essentially, it's like a size of an old school VCR, if you will. It's got the bags of fluid on there. They're all color coded to make it all simple. Connect the machine up at night when you sleep. Put them. Go ahead, go to bed. Over the course of the night while you sleep, the machine's pushing fluid in, pulling fluid out, pushing fluid in, pulling fluid out as you sleep. Supposed to be calm and gentler on the body. Okay. Now, this is the actual catheter in your abdomen. This is what it'll actually look like in your abdomen. These are the machines on the market: the Baxter machine and the Liberty machines as well too. You can see what they look like. As far as the patient experience at home, well, at home, it's a little different, right? You have a patient or caregiver, it could be your wife, spouse, whoever, that does the dialysis for you, right? Either sticks the fistula or helps you set up. You have a nurse on call 24/7. You have a dietitian that discusses diet, okay? And then you have a social worker that handles all insurance issues, transportation issues. And this doctor visit, the doctor visits are pretty much once a month. You come to the office once a month, or nowadays are doing a lot of virtual visits as well. So you have the whole clinical care team. You're never alone. So I want you to think, if you're doing dialysis at home, you're going to be by yourself. You're not. You have a nurse on call 24/7. You have got any issues, you can go into the in-center, go into the dialysis program and just get them to check on you, whatever. So there's actually a lot of support there. Also, what's cool about doing dialysis at home, the diet is less restrictive, y'all. Like, you don't have to restrict your potassium and phosphorus as much as when you're on doing in-center, because the frequency of the dialysis, you're doing more sessions either every day or 4 or 5 times a week. You're getting your blood clean more often. You can less restrictions on your fluid intake and all that good stuff. Get more autonomy, less hospitalizations, and guess what? Better mortality. You live longer. Okay. What I love about this is it puts the patient in charge. And I'm all about like patient empowerment, but I think the only way you get patient empowerment is you've got patient responsibilities, right? Once you're doing something for yourself, it gives you that self-satisfaction that you're actually doing something, but also empowers you to take control, right? So that's what I love about the home dialysis. These are the questions I get all the time. I call this my hey docs, okay? Well, first, my kidneys hurt sometimes. Now, chances are kidney disease does not hurt, okay? There are some people that have some weird pains, but most pain back here, guys, is likely musculoskeletal, muscle and bone, okay? There are types of kidney disease that hurt, specifically polycystic kidney disease and maybe kidney stones. But typically, if your back is just hurting, it's probably just your back, okay? Will drinking lots of water help? Well, we talked about that. If it's acute, meaning you're just dehydrated, yes, it'll bring it right back up. But if you're chronic, been there for a long time, it's probably not going to really do much. And, if you already have issues with fluid, it may actually put you over the edge and make you have more swelling or shortness of breath. These next two, how can I have kidney disease? I make plenty of urine. It doesn't matter. I have kidney disease. I feel fine. These are the kind of denial things we get a lot, where people don't understand that they could have a disease that they don't detect or physically feel, right? And by the time you feel it, guys, it's too late, meaning there's nothing I can do. So this is crucial to get in early. My kidney function can get better, right? Depends. Like, again, if it's acute, you can come right back up. It's chronic. We're talking about either leveling off your kidney function or taking it up a little bit, but it's not going to go back to normal. It's probably going to level off. The last question I get is, will kidney disease fix my kidneys? Will dialysis fix my kidneys? No, it does not. Okay, dialysis merely takes the place of your kidneys because the kidneys aren't working. They're not replacing them. Okay. At this point, thank y'all for being here. Thank you guys for sticking around. Love to field some questions if you got some. If you got some questions, I'll love to field them. Let's put them up in the comment section and we can go from there. Okay, I don't know what any of these mean. Oh, cystatin C, that's the newer test that's coming out. Mario, bring that up. Yeah, that's not commonplace yet, but some people say it's a better marker for kidney function than, say, creatinine is. But yeah. Well, if there's not any other questions, I really love it. Love you all being here. Feel free to put the comments in the comment section afterwards, even after the live, and then I'll answer them as well. Okay, y'all be good, and remember, it's your kidneys, your health.